This one? Wait.
No, on the microphone, there's a sticker right here.
Oh,
Gotta
yeah.
fucking rep that shit,
EMS
dude.
Connect.
EMS Connect. It's fucking everywhere. Shit.
EMS Connect. EMS Connect.
We should start every time we say EMS Connect, just like all point at one of the logos somewhere in the room.
You didn't know.
Okay. That's recording. That's recording. That's recording.
Oh, we're recording?
That's recording.
That's recording.
Talk louder.
Talk louder.
Okay, there you go. Okay. Are you ready? This is BLS Essentials. Altered Level of Consciousness. Thanks, Eli. Appreciate all your hard work.
Thank you.
Thank you. We're sorry.
Oh, sorry.
As always.
You got to earn your money.
Okay, ready? 10 seconds of silence. Are you ready?
Yes.
How about now?
Mm-hmm.
Ready? What does that say?
Memory card is full.
Oh, shit.
That seems bad.
Hold on. Stand by. Memory card is full. Oh. Yeah, fuck it.
Mm-hmm.
Hey, memory cards are full. Okay. 10 seconds of silence. Ready?
Engine 23, and Medic 23, Larpenteur Avenue West and Fry Street. Police on scene. Shooting. Stand by for police. Box 546. On fire off score. Time 21:07.
Hey everyone, welcome to EMS Connect on Shift, your go-to podcast for everything EMS. Sometimes we're going to educate, sometimes we're going to review EMS articles or books, sometimes we just hang out with badass people and BS, but I'll tell you what, every time we're going to have an absolute blast. I am your host, Sean Pitts. I'm the head of education for EMS Connect. We are a top-tier EMS education organization that offers more education than you'll ever need. We have a website with hundreds of hours of education. We got online EMS refresher courses, and we even offer on-site courses. Before we jump into this episode, please take a moment to go to whatever app you're listening to this on right now and subscribe to our show, give feedback, and give our show a rating. Every rating you give truly elevates this podcast and makes it easier for others to find us. Please help us spread the word about EMS Connect and the On Shift podcast so everyone can get educated.
BLS educator.
That was good.
Sorry.
Perfect time to be altered there, Sean. Yeah, so I'm Nathan Dennison, Director of On-Site Education for EMS Connect and instructor of all things EMS related. Previous paramedic. Wow. This is good. We're talking about stroke later, and we're going to leave this in here. You know why? Because of the topic today. Previous paramedic. Edit that, Eli. Holy shit. Previous paramedic educator, and I work in the field. So there we go.
You have the clicker.
Oh.
We're going to start all over. We're starting over. Eli.
Outtake that.
Oh my God.
Holy
the
cow.
whole thing. The whole thing. We're starting over again.
Let's take two. It's the first time we've had the
Oh
take
my
two.
God.
It's hot in here. Why is it so?
Oh, let's turn the fan on.
Please.
All right. Are we? Jesus.
All right, take two.
Christ. That was.
I controlled this.
That was rough.
You were touching the thing, and then I was
Okay.
touching the thing.
We ready?
All right. Yep.
Hey everyone, welcome to another EMS Connect lecture. Today, BLS topic on altered level of consciousness. Couple of housekeeping things we'll get out of the way before we get started. Again, BLS lecture today, so aimed at that EMT level. Advanced EMT paramedics, you're more than welcome to continue watching, but we are talking about specific things related to emergencies and emergency management at that BLS level. Our disclaimer, as always, we are talking about national standards as well as scope of practice in general. We are not specifically talking about a county or a state. So please make sure you're familiar with your local protocols as well as following those local protocols when it comes to treatment today on our topic of altered level of consciousness. We do have an AI disclaimer. Sometimes we use AI generated images as well as closed captioning. So just kind of a warning there. We do not use AI to generate content or PowerPoints, but we might use some AI generated pictures. Quick introductions. My name is Sean Pitts, Head of Education here at EMS Connect, as well as the host of the EMS Connect On Shift podcast. Have the absolute pleasure of working on the BLS side for these education lectures with Nathan Dennison. Nathan, welcome back.
Thank you. Thanks for having me. Nathan Dennison. I am Director of On-Site Education for EMS Connect. I'm an educator of all levels of EMS, and I work in the field still.
Perfect. Well, today we are talking about altered level of consciousness. So what do we got today?
Yeah, so altered level of consciousness. At the time of this recording, we might be altered. But just a quick down and dirty assessments based, a little quick A&P review, some potential causes of altered level of consciousness, how we're going to assess our patients, try and maybe figure that out. A couple of treatment options we may have as BLS providers. As always, we'll kind of wrap things up with a case study to kind of bring together all the things we've just talked about, and then the conclusion with the test. So just some quick A&P review, right? We're not, this is not neurology. We don't need to know the crazy ins and outs of the brain, but just having a general sense of what the different lobes, their functions and controls. So the frontal lobe, it's responsible for cognitive and behavioral functions, kind of some motor control, some cognitive processes, and a lot of emotional regulation. Okay, so the parietal lobe kind of sits mid and on either side there. It's responsible for sensory perception and integration. So temperature or process integrates sensory information from our body, skin, touch, pain, temperature, muscles and joints, and then helps understand and interpret our surroundings and body's position in space. So pretty important on that. Also has some motor control, spatial navigation, like I mentioned, and attention and awareness. Temporal lobe, auditory processing, memory formation and retrieval, and language comprehension, as well as some visual perception as well, and does participate in emotional regulations as well. The occipital lobe's sitting in the back there. There's a lot of visual perception, so object recognition, visual memory, spatial awareness, and then visual imagery, right? So it's pretty important for our eyesight. The cerebellum sits near the base there, so it does a lot of muscle or motor coordination, motor learning, posture control, some cognitive functions as well. And then the spinal cord is it transmits all of our electrical signals from our brain down to our nerves and muscles, and kind of helps us function, right? So if that thing gets taken out, then we're in big trouble. So it's a quick A&P review. Like I said, we're not diving into the neurology aspect of that, right? So
I think it is important to understand the A&P, especially when you understand, we start looking at strokes, where that clot or possibly hemorrhage is occurring.
Yeah.
You can actually understand of why it affects, why is the FAST exam a great assessment tool, because of where that vessel is and what it actually, what it takes oxygen and blood to and so on. So even though A&P seems to be overlooked by a lot of BLS providers, that's why it's so important to dive a little bit deeper into the A&P every time we do one of these.
Yeah. And outside this training, I recommend everybody kind of just make sure you're familiar with all those aspects, right? Because like Sean was saying, when it comes to the stroke, depending on where that blockage is in the vasculature of the brain, will present in different cases or different scenarios, right? So why am I altered? Why am I altered? Probably because of a lot of working lately. But when we go on these calls, we might get a brief altered level of consciousness dispatch, right? And it's up to us to determine why somebody is not acting appropriately, right? So there's a list of things here. The next slide will dive in, which show different acronyms that have been used. But let's start on the surface level, right? There's a couple easy things that we can test for and try and rule in, rule out as causes of altered level of consciousness, right? So one of the biggest ones is hypoglycemia, right? So we get called to a patient who's altered. They have a history of diabetes, say maybe they're insulin dependent, and they're just not acting right. So with our brains, it requires a lot of oxygenated blood and a lot of sugar, right? So the hypoglycemia aspect is one where, we have to understand hypoglycemia, a brief understanding of how diabetes works, right? So either we're type 1 diabetic, our pancreas does not produce insulin like it's supposed to. So that's usually, early onset, childhood onset. There is some instances where we can have later onset from that, but they have to take insulin because their body's not producing it. The other one that we'll see quite a bit is the type 2 diabetic, or otherwise known as maybe adult onset diabetes, or essentially this is just a metabolic dysfunction, right? So we eat food to energize our cells. And in order for that whole process of the breakdown of food to turn into the glucose, to glycogen, to all that stuff that is way beyond BLS level, we have to have insulin that will help those cells uptake that glucose to create energy for us. So when we have insufficiencies of that, usually it's insulin resistance, then we'll see that dysfunction, right? So again, what does that mean? My sugars is low, right? I'm going to act goofy if I can't process or uptake those sugars into my tissue, or I'm running a little low because I took too much insulin and maybe I forgot to eat, right? So that's an easy one to test. And we'll talk about the assessments here in the next couple slides, right? So hypoxia, low oxygen. Again, we require a lot of oxygenated blood in our brain for it to respond and act appropriately. So anytime we see a decreased level of oxygen, then we can start to act goofy on that, okay? Some other ones are, intoxication, whether it be, drug-induced and or alcohol-induced. Those are poisons that we ingest, either intentionally or unintentionally sometimes. And then depending on, the alcohol, it creates a metabolic chemistry process that, again, we're not going to get in here, but we have a couple beers, have a couple cocktails, whatever you drink, and you become intoxicated. The drug overdose is the same thing, right? So if I take any different number of drugs, I can become altered from that. The opioids are one that we talk about because it's a CNS depressant. So anytime we have a depressant type action, either with alcohol and or the drug that we're consuming, we're going to become altered. Delirium. So this can be caused organically or inorganically, right? So when we talk delirium, we have Alzheimer's patients, dementia patients, they have their times where they're cognitively appropriate and other times where they're just not acting right? That's something that we can't really determine out in the field, but again, we'll talk about assessments here in the next couple slides and what we can actually do about it. Head injury. So anytime we have a head injury, we increase intracranial pressure in our head. That creates pressure on our brain, which is not going to allow the vasculature to provide oxygenated blood to different areas. We're going to become altered. Back to point number 2, right? Brain infection. So encephalopathy is kind of a broad term brain disease. I've had quite a few patients where I've had altered level of consciousness, or they're acting like a stroke or something like that. And following up later on, they're like, oh, they had encephalopathy, right? So what is encephalopathy? Just a broad term for a brain disease, either caused by infection, stroke, or a couple other things, right? Body temperature. If I get too cold, so if we're hypothermic, then we start to go into a hibernative state, right? When we do that, our bodies are going to try and shut down. We decrease metabolism, decrease oxygen uptake, because the body knows that, hey, I need to preserve myself so I don't die of and freeze. On the other side, hyperthermia, heat stroke. So we're coming into springtime and summertime, so that's one we got to get caught up on, right? Heat stroke is the true emergency. So your body is unable to regulate temperature anymore through its cooling mechanisms, and then we start to heat up our brain, and you scramble your brain like an egg in a frying pan, right? Brain tumor. Again, it's not usually the tumor itself that's the issue, but as that tumor grows, it'll put stress and pressure on different areas of the brain depending on where it's at, and decrease vasculature, increase of altered levels of consciousness. And then stroke, right? So we talk about ischemic stroke, so a blockage in a blood vessel, or hemorrhagic brain bleed. We don't really like to call those strokes because it's not really what it is, right? So again, if we have bleeding outside of our brain that's putting pressure on the brain, decrease in cerebral blood flow, going to cause alteredness. And then, of course, on the other side, the stroke, the ischemic stroke, we have a blockage of that blood vessel. Depending on where it's at, we're going to see different signs and symptoms, okay? Another one that we talk about is this acronym, right? It's been around for forever. So AEIOU TIPS, again, just a bunch more reasons of causation of altered level of consciousness, things that, we need to be aware of, but, truly it comes down to our assessments, right? So the assessment tactics, biggest one, be a good detective, right? So if we have a patient who's altered, they're not acting appropriately to us, hopefully we have a good historian on scene that can hopefully provide some history for this patient, right? So friends, family members, and we get into questionings like, big one is, when was the last time this patient was seen normal, right? So we can we're looking at time frames with that type of question, right? If we're thinking maybe a stroke, or a stroke would be the big one because that falls into the treatments later on in the hospital. But when were they acting normal last, and then what changed in this current state, right? So another one too is usually when we're talking to patients and they seem off to us, if we have friends or family around, ask them if that is normal, right? Because different disease processes, the Alzheimer's, the dementia patients, they might say, hey, yeah, it's not normal for them to be, as we consider A&O times 4, right? Alert to person, place, time, and event, okay? So moving on from that, alert and oriented, that's just the simple questions. What's your name? Who are you? So person, where are we at? What's your address here? Do you know where we are? What city is a good question, state, stuff like that. What day is it? I like to ask that. Although usually when I ask that, I don't know what the day is because it's just a work day or a not work day. So I usually have to verify that they are correct, but hey, it keeps both of us on our toes. And then the event, like what's going on? Do you know why we're here, what we were called for? So simple questions like that. The GCS, that's more trauma-based, but it's still good, right? So we have our 3 categories: eyes, motor, and verbal, and then the varying degrees of that. So it's just we're just trying to sense where we think that patient is. Are they with it or are they not, in the most basic terms?
I think it's important to remember with your GCS, if you take an initial GCS, let's say it's 11, after you have corrected correctable things, a glucose issue, a hypoxia issue, Those are probably the two most correctable, right? Then retake a GCS and determine now we have a GCS of 15, which is probably more normal for that patient after we fix the sugar issue or the hypoxia issue.
Yeah, absolutely. And that falls on to the last point with the vital signs. We always want that starting point, right? So same thing if we're suspecting a hypoxia, right? Somebody's low oxygen saturations, I want to get a good base level reading. And then the ways I can fix it as an EMT provider, I'm going to do that. And then we're going to reassess and see if it actually worked, right? And that's important too on your documentation when all of this is said and done with this patient care is, writing down what your initial assessments were and then your follow-up assessments to show that, hey, on paper, I helped, right? FAST exam, working on becoming the BFAST exam will be the newest thing. So that's essentially just assessing simple functions of the brain, right? We're trying to determine large vessel occlusion strokes is usually what that is. So F is for face, so they have facial droop, one side or the other. Arms, do they have weakness in grip strength, or can they maintain a posture of arms raised? Speech, what does it sound like? Does it sound slurred? Are they able to speak at all? Or sometimes you'll see patients who are trying to talk to you, and then one of my follow-up, if they're not doing a good job at that, it's kind of a simple head yes or no. Like, do you know what you want to say and you just can't get it out? That's a positive finding for speech. And then the time is that last time seen normal. Again, that's for treatment options when we get them to the hospital. Okay. Remember with FAST exams that any one of these that are off are FAST positive, right? So a lot of the times when we have that, obviously if they have facial droop and they have arm drift or weakness, and everything's on one side of their body, then that could possibly be an ischemic stroke. A lot of times providers will get held up with that speech, right? So they're FAST negative, except their speech is slurred, and that's not normal according to family. Well,
that's FAST positive.
That's FAST positive, right? So we are not in the field of diagnosing true stroke, but if something is off and the story kind of fits, then we're going to run it in as a stroke alert and let the physicians at the hospital do all the tests that they are able to do and figure it out, right? What we don't want to do, and we'll jump down to the vital signs, so there's some stroke mimickers in that aspect, right? So hypoglycemia is one of those where if their blood sugar is low, they might have those deficiencies in that FAST exam, right? So that's part of our ruling in or out of an actual stroke field diagnosis. So make sure that you're doing those. A lot of, that encephalopathy I mentioned earlier, I've had quite a few patients who presented like a stroke, and then they turned out to be maybe a little septicemia. So they had an infection that was kind of going globally, and it affected their brain function. So, but that's not up for me to determine, right? We don't have those means in the fields to actually rule those in or rule those out. Okay. Trauma, we always want to suspect trauma, especially when we're dealing with issues that could be affecting our level of consciousness, right? So if we have any history of recent trauma injuries, falls, trips, falls, remember that for head bleeds, depending on what happened for that bleed to occur, we might have a delayed onset, right? So if we have an altered patient and all of the rest of our vital signs, so they're not not hypoxic, not hypoglycemic, blood pressure is probably a little high, maybe our heart rate's a little high or a little too slow. Good detective work with that friend or family member is have they had any recent falls, right? So, and we're looking for greater than, maybe 72 hours of a fall, say. And so if we have evidence of that, then that could be a head bleed, not necessarily that stroke, right? So vital signs we talked about already. And I don't think we can hammer that enough, right? Vital signs are vitally important, especially when we're dealing with brain activity, right? So finger stick glucose monitoring is paramount. Should be done on almost every patient, because it's going to be in normal range or it's not, right? And maybe they don't know that they have diabetes yet or a metabolic insufficiency. And through our good assessments and vital signs that, hey, we want to get this checked out as well. Same thing with oxygen levels, right? So good baseline oxygen level, and making sure that the patient is perfusing well enough so that we're getting an accurate reading, right? So remember that peripheral vasculature, if a patient is cold or showing evidence maybe of trauma, then the body is going to automatically shunt blood to the core to keep the core warm, and it will shut off the peripherals, right? So all the extremities. So if I have cold hands with poor capillary refill, then you're not going to get a good reading on those fingers with that pulse oximeter. Blood pressures is important, right? If you have the capability of having that monitor, fantastic. But when we're talking about altered level of consciousness, just like in the trauma setting, we want a good baseline manual blood pressure. This will be one of those ones where we want an accurate reading, right? So they might not be hypoxic, but they're also have another disease process going on where they're not perfusing as well. Maybe they're septic, right? So global infection that kind of gets into the bloodstream is going to start affecting our vasculature and start, permeating and leaking infection further on. So that could cause hypotension. So don't be afraid to do a manual blood pressure. We should be efficient at it. And, if you do a manual blood pressure and then you follow up with a blood pressure on your monitor, if you have one, and it's reading, within a couple points, then fantastic. We can keep that. The monitors that we have are great. I'm not bashing those whatsoever, but they are fairly sensitive and they can't differentiate a pulse versus somebody who's tensing their arm, right? So that will always can throw that reading off. So just be aware of that.
Yeah, a couple of things to kind of go back to. Number one, another mimicker that's really common, I shouldn't say really common, but is Bell's palsy, right? So that can be a stroke mimicker as well. We do have a great lecture. It's this month actually with Dr. Dang going over just strokes. Nice. So the different fast exam, LAMS score, when to use fast, when to use LAMS. He even went and found a bunch of great other exams that are used all across the country. So if people aren't familiar with LAMS or I think everyone's pretty much familiar with FAST. He is going to go dive a little bit deeper into now BFAST, which is balance and eyes are your two additions to that. So kind of watch out for that. I know you hit it, but I know taking a glucose is not considered a vital sign because it's a procedure. Arguably, it's invasive, but it should be something that we as EMTs are doing, like you're saying, almost on every patient. It's justifiably. You can take a glucose on most of your patients. Absolutely justifiable if they are altered in any way, shape, or form. Glucose becomes a paramount thing you need to obtain. And then with the last one with vitals is I can't stress enough, especially since syncopal episode, that fainting episode could be the reason why they're altered. I think a baseline blood pressure of sitting and then a blood pressure of standing. And do they have any of those orthostatic changes? I think is something to be adding into the BLS toolbox of that should just be something we're doing on a majority of our patients. If they'll tolerate it, there's no reason not to do a complete thorough assessment to rule out and maybe catch things or just get practice on some of these things maybe we're not as used to.
Yeah, absolutely. And that syncopal one, we can hang on that for a second because that becomes fairly tricky. We get reports from dispatch, somebody calls in, hey, my family member passed out, but now they're awake, right? Why is that? What was the cause of that? Is there anything that we can do to maybe reproduce that, being those orthostatic blood pressures, right? They've been sitting for a long time and they stood up suddenly and they had an imbalance of cardiac output to maintain homeostasis and they dropped their blood pressure, dropped their oxygen levels to their brain for a second, then, they're going to pass out. Maybe we can get them to do that again.
So in a controlled, safe environment.
Yeah.
Let's make sure we're holding on to our patients.
Don't cause trauma trying to.
Let's try to reproduce
this. Yeah. And always the conversation with that is, hey, we're going to take this blood pressure sitting down. I'm going to have you stand up and I'm going to take it again. If you start feeling dizzy or you can't stand up, please let us know. We'll sit you back down. If they if they tell you that they can't do it and you don't get a accurate blood pressure reading, well, then that's orthostatic positive, in my opinion.
And the other positives drop in 20 or more systolic blood pressure and a rise in heart rate. I always forget the heart rate one.
We're not out.
But I know. Drop in 20 or more systolic blood pressure for sure positive.
Yeah.
I can never recall the heart rate one.
The heart rate one, so your heart should speed up to try and compensate if you have a drop in blood pressure. But through your assessment and the medications that they're taking, they might not be able to raise their heart rate through some of the beta blockers and other cardiac medications. So the medications too, right?
Yeah.
Be a good detective, ask about medications, obviously.
Especially new ones in the last couple of days, maybe nausea, vomiting, that dizziness could all be side effects of some sort of new medication they're just not familiar with.
Yeah. And again, with the medications, there's a lot of medications out there. We don't expect you to know them all, but again, some of them you're going to become familiar with because you're going to see them over and over again. And if you're not sure what the medication is, ask about it. All right. So that brings us to what can we do about it as EMT providers? Well, it depends on what's going on, right? So if we can figure out a cause, that's number one, right? So the basic hypoglycemic patient, you have a type 1 diabetic who took his insulin and he didn't eat afterwards because he got busy, or he took his insulin and he didn't check his blood sugar like he was supposed to prior to giving himself insulin. That's a good cause for altered level of consciousness. And as long as they're alert enough to be able to swallow, then we can fix that as EMT providers through oral glucose, right? And it works magic. There's a little bit of delayed onset. So remember that if you give somebody a tube of glucose and, refamiliarize yourself of how we're supposed to administer that. Maybe we'll cover that in a later session on pharmacology, but there is a way that we're supposed to actually give it, not just have them take it, just eat it,
like cake frosting.
Right. Even though that's kind of what happens. But anyway, there's a little bit of delayed onset for that stuff to take effect. So just be aware. And then that would be one we would want to reassess, right? Reassess mental status or finger stick blood glucose. Hypoglycemia or hypoxia, rather, same thing, right? If a person's low on oxygen, we can give them oxygen. And if that corrects it, fantastic. But then we have to kind of dig into why they are hypoxic and should be transported for evaluation. So that brings us to treat what you can, right? If we have an altered level of conscious patient and we've done the vital signs, we've done the finger stick blood glucose, and everything comes back within a fair range. I wouldn't say normal range because what's normal, but if that doesn't jump out at you to the cause, then now we just need to work on transporting supportive care and maybe calling for help if we're able to. If you have ALS providers that you can call, or if you're far enough away from the hospital, maybe that would be one where you want to call for a helicopter to transport, because being altered is not normal, right? And not necessarily that your call for help, your paramedic partners or whoever will be able to fix the altered level of consciousness, but it's an extra set of hands, an extra brain that is functioning somewhat appropriate, and maybe trying to figure out what else could be going on for this patient to be altered, right? And then when in doubt, use the gas pedal, diesel pedal, whatever you have within
electric
pedals. Yeah, just get them to the hospital.
Sorry to jump in and interrupt, but all successful podcasts have advertisements. This podcast wouldn't exist without EMS Connect, an online, self-paced CE platform for all levels of EMS providers and firefighters. Our site houses over 140 hours of nationally accredited content for all levels of EMS. Access to our site is only $7.50 a month. There are no join fees, cancellation fees, and definitely no bullshit. We also host monthly live sessions where you have the option to interact with our talented and engaging instructors. Just for listening, you will be automatically entered to win a $50 Amazon gift card, which will be drawn at the conclusion of each of our live sessions. All of our courses we offer can be easily imported to your NREMT profile with a few simple clicks. This greatly simplifies your recertification process. All of this can be yours for only $7.50 per month. In this economy, we're spending more than that on our daily coffees. But wait, there's more. Our site also offers EMT, advanced EMT, and paramedic level NREMT refresher courses that are 100% online and self-paced. For all of your training officers out there, we make your job super easy with our administrative tools such as uploading agency courses, skills tracking, participation reports, and so much more. To get a no-catch peek at the administrative tools and capabilities of EMS Connect, contact us at info@emsconnect.org. Again, info@emsconnect.org. All right, enough of the advertisements. Let's get back to this great episode.
Anything else on that before we jump into our case study?
I know it probably seems like this lecture is a little bit on the shorter side, but if you go back to that list of possibilities in altered level of consciousness, you could have hour-long lectures on individual topics.
Yeah.
The idea of this is recognizing altered level of consciousness. Let's throw that huge net of possibilities. Let's narrow it down what we can by treating what we can, and then getting them to the hospital. Even at the paramedic level, right? Treatment for a head injury, not a whole lot is done in the field. Treatment for a stroke for an ALS provider versus a BLS provider is identical, right? On the glucose side, really the only addition is a paramedic may be able to administer a medication IV or IM, but realistically, no level of pre-hospital providers are giving insulin. So it's not like we can treat the hyperglycemia side of things. So really, this lecture is about throwing that net of possibilities, have a general understanding of kind of what's going on. We'll go through this case study, and then if you want something more on stroke, then there's lectures on stroke. If you want something specifically on heat-related emergencies, then there's stuff on heat-related emergencies. This is not going to be an all-encompassing lecture about altered level of consciousness, because that could be
several
a 24-hour refresher in itself. So
would definitely be several hours.
Yeah.
And if you want that, let us know. Break it down into series. Because,
yeah, absolutely.
Yeah. The brain is very, very complex. It's very interesting. And, we don't want to fry your brains trying to give you all the information. So, yeah. So let's get on with our case study. All right. So just a simple case study to kind of wrap things up on altered level of consciousness. So you're called for a 56-year-old male who was just not acting right per his family member. The caller states she came home and found the patient walking around the house, not making any sense. There's no weapons and the patient is nonviolent, which is pretty important to know, right? When we're talking about scene safety. And if he's walking around not making sense and caller states, this patient is altered, then we need to be aware of that. Not that he's going to conscientiously harm anybody, but if he's, altered, that they can have some violent tendencies. Again, it's not that they're maybe mad at you, but they just can't process what's going on, right? So in this instance, what are our initial thoughts? And this is building our differential diagnosis, but what the possibilities would be.
I mean, this one, the possibilities are endless, right? We don't know anything. This could be arguably, you're probably thinking it's not a chronic onset, right? Because the caller seems to be worried enough. This probably isn't normal, right? So probably something a little more acutely a possibility, right? So hypoglycemia, hypoxia, drugs and alcohol obviously could be a possibility. Throwing just a weird unicorn in there, maybe there's some sort of CO poisoning in the house. The wife just came home and found him like that. So if she starts developing signs or symptoms, or anybody in the crew starts developing signs or symptoms, might be something just a unicorn to throw out there. But
yeah, we can expand that to behavioral emergencies, right? Mental crises, infection that's gone untreated or not treated well enough, causing global infection. I mean, your differential diagnosis in this instance, when you have such vague information, should be everything. Right.
The AEIOU tips. That's your differential diagnosis.
And if you can remember every subcategory,
bonus point on the exam.
We
can't give it to you.
No, there is no extra credit. All right. So you arrive at the house to find a male patient who is wandering around. Who wrote this?
Nice job.
Thank you. I was altered. He acknowledges your presence. So when we walk in, we're getting our door assessment, right? So you walk in and he looks at you. So that's kind of a positive finding. He is wondering. He's wandering around. Maybe he's questioning everything. He is A&O times 1. So basically you ask his name and he tells you what his name is. Okay. He doesn't know anything else other than that, right? His skin is clammy and warm. Pupils are equal and sluggish at 4 millimeters. He can follow basic commands, so we don't want him wandering around or wandering around while we're trying to assess him. So we have him sit down, and he does so. So how do we approach our assessments with this?
In this case, I would say this can be a little bit of a slower approach, right? Asking permission to do things that we were not, setting him off, not like in a negative way, but alarming him. And then I say we go for those basic vitals, right? Blood pressure, heart rate, room air saturations would be great in this case. Maybe split your crew while one person is having a conversation with patient. Since he's alert and oriented times 1, having some basic yes or no questions about pain, shortness of breath, things like that. But then having a conversation with that caller, if the caller happens to know him, medications, past medical history, allergies, that kind of thing.
Yeah. And this dives into that being a detective, right? So we're evaluating our environment. Is there anything apparent that could show cause of why he's altered? Utilizing the friend or family member, whoever called.
What was the age of our patient again?
56.
56. All right.
Yeah.
Just logging that in my brain.
Yeah. So, as we start working through our differential diagnosis, one of the causes of altered level of consciousness are drugs. So usually a CNS depressant, like maybe an opioid, will show outward signs of pinpoint pupils. So maybe we can rule that out, but maybe we can't, right? But at this point, trying to talk to the patient, like Sean said, this is a person who is, he's reacting and following your commands, but he still doesn't know what's going on. So we don't want to bombard him with questions from multiple providers, right? We might not get the answers that we want or in the timely manner that we want because we're trying to figure out how we can help them. The last thing we want to do is have multiple people asking different questions. Maybe pick somebody, whoever initiated the contact. If he was responsive to that provider, have that provider do all the questioning and the hands-on physical assessment until it's not working anymore, right? All right, so wife states that she went to the store about an hour ago. Her husband, so we found out relationship, right, was fine at that time. He has no known drug allergies. He takes metoprolol, simvastatin, and insulin. So if we don't gather anything else about her history, knowledge of basic pharmacology, metoprolol is a beta blocker, simvastatin's for high cholesterol, and insulin is for type 1 diabetics, which he has a history of. She is not sure when he ate last, so part of our sample history. And then in this instance, is there anything else we need to know? One thing maybe, do you know if he took his insulin today, right? And was it the fast acting or was it maybe more of a slow onset Lantus type stuff, right? So that might be a good question we want to know because, we might jump to the assumption that, he's type 1 diabetic and she doesn't know when he ate last. So he took his insulin and then he didn't eat, right? Probable, but let's ask those questions of if she knows when he took his insulin last, because, we're still working through a differential diagnosis. We don't want to just jump right in this instance to a hypoglycemic emergency. All right. So vital signs, his pulse is 110, blood pressure is 164/86, respiratory rate's 22, SpO2 is 95%, blood glucose finger stick is 46, and temperature is 97.6. So yes, you might have a glaring vital sign that is pointing at you, but let's evaluate everything else first, right? So he's sitting down and his pulse rate is 110. Now, that is outside of the book knowledge of normal, right? But is there a causation for him to be a little bit tachycardic in this instance? And maybe so. Blood pressure is a little bit high. So again, with altered level of consciousness, we want to ask about any recent traumas, specifically head traumas, if we're concerned about a head bleed. Oxygen levels, 95%. We're getting a good pleth wave with our SpO2 monitor, which in this instance we are. So he's perfusing appropriately. He's in a warm environment, so he's got a good cap refill, and his hands feel warm. So we can take that as accurate. And then he doesn't have a temperature, right? So we talked earlier about reasons for altered level of consciousness. Infection is a big one that can be missed a lot of the times as a causation of altered level of consciousness. But in this instance, we're not going to get too crazy. His blood glucose is 46, which is abnormal, right? One of the good questions with this, and yes, on book, in text, this is not normal, right? And he's acting inappropriately, so that is probably accurate. With the blood glucose, I always like to ask my diabetic patients and their families what their normal readings are, right? Because we can get a baseline of where they're at. If they're stable, then yes, definitely. But we can have some fragile or brittle diabetics, as we call them, where they have huge glucose swings because they just can't. They're not eating the right foods, or they're not taking their insulin like they're supposed to, or they're trying to dial that insulin dose in. So just ask those questions.
When I think EMTs, we tend to like hook on the book, like you're saying, of like, what does the book say is the range of normal? Mm-hmm. Pulse is a perfect example, right? It's 60 to 100 for an adult. Okay, well, this guy's at 110. Is that tachycardia? Sure. But does it match the story? Well, he's been up wandering around the house. His body clearly is in some sort of, crises, right? Yep. The 55-year-old male who wakes up with chest pain and a heart rate of 90, you get an EMT who says, well, 90 is within the normal limits. Well, waking up with a heart rate of 90 is not a normal finding, right? So in this case, again, blood pressure, he is hypertensive, but he also has a history of hypertension. Glucose, like you're saying, I think a lot of providers we see, anything over 140 is a hyperglycemic patient. Okay, well, there's lots of type 2 diabetics who live in the 200 range, and that's quote unquote normal for them. Mm-hmm. Is that the reason to take them to the hospital? Well, probably not. Are they hyperglycemic according to the textbook? Absolutely, but not necessarily the reason for the emergency. Now, their glucose is 700 or 600. Now, that's the hyperglycemic crisis that we're talking about, and definitely means of some sort of alarm. So don't get caught up into like memorizing ranges, right? Know what is normal, but then pair it with what are you currently seeing, and does that seem to fit the story?
Perfect. All right, so treatment. We have a medication that we can give this patient to maybe help our current situation. We have to ensure that he can swallow so we don't cause a choking hazard and or make things worse for us. So he is able to do that. He's able to follow your commands and appropriately swallow. So we give him some oral glucose, 15 grams. PO means by mouth. So again, there's a delayed onset with this medication when we're using the oral route. So after several minutes, the patient starts to become more alert. His skin signs dry up, which was always good. He apologizes for you being there. So he's a very nice patient, and states he was busy and forgot to eat after taking his insulin, right? So we're able to complete this story after we give him our treatment options, and he becomes more appropriate.
If this patient wasn't able to swallow, and I know in some areas glucagon is an option for EMTs to give them another tool in their toolbox for patients, would this be a applicable scenario for glucagon?
It could be.
Let's say he wasn't able to swallow, and let's say his glucose was a little bit lower. I'm just playing devil's advocate.
He's becoming more altered. Yeah. Say he's not conscious and all. Not able to swallow. Yeah, then absolutely. Right. We do
in this case. Yeah. If he's able to swallow, then by all
Right.
means go with the oral glucose. But
Yeah.
I was just saying, let's change the scenario a little bit.
Sure.
And he's not able to swallow. You don't have ALS at your disposal to be able to give, D10 or anything like that.
Perfect.
Would
Yeah, that's
glucagon be
the
applicable
key.
here?
Is there any other providers who are able to start an IV and give IV route sugar? Then yes, glucagon would be appropriate. We don't want these patients' blood glucose to go any farther because that can cause serious issues, seizures, death, which is not good. So yeah, glucagon would be appropriate. Remember that if we are giving glucagon, those patients need to be transported to the hospital for evaluation. The other thing that I would say too is if we go back and we alter this case a little bit, and he's a type 2 diabetic who takes maybe like a glucophage or metformin, some type of oral diabetic medication, we don't usually see hypoglycemia in those type of patients. So there might be something else going on. They should be transported for evaluation. But absolutely, if we're giving a glucagon because it depletes the stores in the liver, they need to be evaluated and looked at for.
All right. So this guy, right?
Yep. This guy did not have any of that.
Yeah. Didn't have any of that. He says, pretty great story. I was busy, forgot to eat, took my insulin. But you gave this guy a medication. Now we know what this is going to. He's going to say, well, I don't want to go to the hospital. That's ridiculous.
Yeah.
Does this guy get to go to the hospital? He was alert and oriented ×1 a minute ago. You gave him a medication that has corrected the issue, but now he doesn't want to go.
Mm-hmm.
So most EMT textbooks are going to tell you he needs to go to the hospital.
Right.
99.9% of these, we know we've allowed to sign the refusal. So what's the standard there?
Yeah, so it's not just an easy thing of, a person becomes more alert and says, I don't want to go to the hospital, and say, we leave, right? Obviously, we're probably going to get there, but you have to do a thorough second assessment, right? So he was ANO ×1 when we first encountered him. Is he now ANO ×4? Our glucose was 46 when we first checked that. Now, what is our glucose after several minutes, and he's acting more appropriately? Is it more in that quote unquote normal range for him? Is his wife going to stay home now and watch him? Right. So the instances of reoccurrence of hypoglycemia are they can happen. Right. The glucose that we give is fast acting. It is not. It's just pure sugar, right? So it's not going to hang around. The body will use that, especially if all of his cells need it. A good follow-up meal is appropriate for this, right? So some complex carbohydrates, some proteins, stuff that's going to stabilize his blood sugars. Are any of those foods available for him, right? So those are the things that we have to do. We have to ensure that this patient is able to make his own decisions and understand the risks, because yes, we had an easy fix for him, but the risks are still there, right? The other thing that we want to know is, has he had any recent changes in his insulin medication? Does he use a sliding scale? Did he check his blood sugar before? Because if he has more insulin than we give him sugar, then he's just going to become depleted again. So not saying that all these patients have to be transported. We do have to offer it to them still, right? We arrived as a 911 call. So we're there to treat, we're there to transport if they want, leave it up to that patient, understanding, the risks if he is going to stay home. And most likely, he's probably not going to want to go to the hospital in this instance.
This guy's pretty much going to refuse.
Yeah. And just so happens that his wife was gone for an hour at the grocery store. So she's got plenty of food, good foods to.
When I think doing a quick head to toe assessment, making sure he didn't have a fall during his period of being altered, that's hiding somewhere.
Good assessments and good documentations in this, because this turns into a treatment and refusal. So we have to.
Huge liability there.
Yeah. On paper, justify why that occurred. So that's it. Again, pretty brief one, but like we were talking about earlier, we could go on for hours and hours. But in this instance, we're just understanding the basics of A&P. Look into those different areas. It's always good to be aware of what the different lobes are responsible for. Knowing the causes of altered level of consciousness, they're vast and there's a lot of them. being a good provider, good detective, doing our great assessments, and treating what we can. That's right, Ty.
I was just going to ask you, how many days had you been working when you?
Probably all of them.
Yeah.
Yeah. So, man, there's a bunch of altered level of consciousness.
Bonus point. If you can correctly determine the number of typos on this lecture, bonus point on the exam.
Yeah, that's going to be an exam question for sure.
Mm-hmm.
Fantastic.
Maybe we should go through and find them and have it an exam question.
I might have to do that. Probably not when I've been working every day of the week.
Yeah.
But anyways, that's all we have for this episode.
Hey, thanks for checking out another episode of EMS Connect on Shift. Please subscribe, review, and rate our podcast on your favorite platforms. Those ratings really help our podcast grow and reach new listeners. Also, make sure to like and follow our social media sites by searching EMS Connect on Facebook, Instagram, and YouTube. Thanks for getting educated with EMS Connect.